If I could ask you to please take your seats as we are about to begin. Those of you who are joining us hosted by MSF, welcome to you, and welcome to those of you online as well. It's the WHA, and the distinguished speakers for the first panel have other commitments they have to get to. We're very grateful that you could be here anyway, but we're going to be a little bit brisk in the way that we run the show today so they can get to their other appointments. Without further ado, I'd like to hand over to the Executive Director of DNDi, Dr. Luis Pizarro.
Thank you. Thank you very much, Springs. Thank you very much, all of you, for being with us today. So, as you know, we are celebrating the 20th anniversary of DNDi. Since I arrived to DNDi, I like always to start by saying thank you to the founders, the organizations that created DNDi 20 years ago. You will see here in the wall all of them from America, from Africa, from Asia. They were absolutely key at the beginning. They are still today with us, and we're very grateful for the support they are giving to DNDi. I want to be very, very short and just maybe respond to the question you can have, why DNDi is talking about universal health coverage. We are an R&D organization working for neglected diseases, and it's really a question we have been developing those last months because we consider that neglected diseases, neglected populations are a very, very good test of universal health coverage. We cannot talk about universal coverage if we're not addressing the needs of those neglected populations. And this is the reason why we wanted to talk about that. And second, why we're talking about inclusive tools to address universal health coverage. It's because the work of DNDi from the beginning start with patients, with health workers at the primary health level, at the community level. And this is the way we try to include the needs of the patient in all the research and development we are doing. So for this, we need, of course, political leadership, and thank you for all the political leaders here in the room. And we need to engage discussion here at WHA, in New York in September, and everywhere where we're going. So this is what we're going to start doing today with you, and I will give you the floor immediately. Thank you very much again, all of you, for being with us today.
Thank you very much, Luis. Inclusive innovation. So Jeremy, I think it's fair to describe you as a mainstay of global health. For those of you who don't know him, this is Jeremy Farrar, Chief Scientist at WHO. He has headed big philanthropy in the sector. He has worked as a clinical scientist in the field. He knows the good, the bad, the ugly, the absent of inclusive innovation. And so we have all committed to a new way of doing business after the COVID pandemic, or we claim to have. And what might this new way of business look like, to your mind, where we consider everything from innovation to access, and everyone from the most neglected to the wealthiest? How are we going to get inclusive innovation? How are we going to make it work for UHC, and who is going to do it? 5 minutes, solve the world's problems.
So it is a pleasure to be here. 20th. I thought I seemed to have been at a birthday party of DNDi before for 20th years, but 15. Maybe I'm inventing 15. That. 15. Okay, 15. And pay tribute to everybody that's played a role in it. Old leaders, not old, but leaders in the past, and leaders here currently. So thank you very much for the invitation. I have been a part of DNDi from the outside in many different forms, from being a clinical scientist in Vietnam for 20 odd years, and then as a funder, yes, and I hope now in future in my new role, which I was asked after a week this morning at the briefing for the start of WHO that Dr. Tedros ran, what my first thoughts were after a week. And I chose my word very carefully on the moment of bewildering, which I thought was positive enough, but gave a message of being slightly bewildered by the way of this new life that I'm leading. So my thoughts are really a reflection of my past life, the good, the bad, and whatever else. I think the good, and we've all experienced it, is when there is togetherness in the way stuff happens. And the bad is the opposite of that. And what I mean by that is the good, and we've all been there. And I was thinking this morning before coming of, where DNDi has played a role in this, played many roles, but perhaps I would just pick out what it did on hepatitis C as the example. Patient orientated, patient listened to, patient involved, patient engaged, science. And I appreciate the introductory comments which said that DNDi is a R&D organization. I don't think you are an R&D organization. I think you're an everything organization. You're at the clinical interface, you're at the epidemiological interface, because that's where your information comes from. You're a clinical science, you're an epidemiologist, you're a public health science, and you're also ensuring that whatever is done there is then delivered to the people that need it most. That's not just an R&D agency. That's more than that. That is the togetherness that I talk about. Now, apart from family and clinical science, my other great love is of sport. Great sports teams, but it's the same in great orchestras, it's the same in great organizations, evolve as the times change. They don't drop off a cliff and reinvent themselves, they evolve all the time. And I think DNDi has been inclusive, it's been argumentative. We haven't necessarily always agreed. No. It's been at the edge of what's acceptable diplomatically, scientifically, and others, but it's pushed the boundaries. And you can't do that unless you are slightly edgy, but you also can't do it unless you're willing to work in partnership. Then thinking about my new role, and this is, as our lawyers have said, I'm commenting as of my previous life, not my current life. That's what I hope that the WHO is and can be, that it is there as a facilitator, it's there as the global public health agency, but it's there to work in partnership with others to make others succeed and to deliver the best public health and clinical that we can to the people who we serve. And reminding ourselves of that role, that critical convening role, but also the role that allows others to shine, I think is a really important role in my future. So togetherness and anti-non-togetherness, and realizing you can't just do R&D and not consider the start, the patient, and patient-oriented, and you can't consider it unless you've delivered what your R&D did.
Thanks. Dr. Keeney, you are very many things, including Knight of the Grand Order of several things in France. I'll read it here. Chevalier de l'Ordre National du Mérite.
Du mérite.
Yeah,
Merit.
Mérite, okay. You're a clinical scientist yourself. You have been at the WHO leading several departments and as an ADG. You are board chair of DNDi. And Jeremy has just said he would like the WHO to be modeled on DNDi. So in those 20 years.
Did you?
Something like that. Well, are there elements of the model of DNDi, of collaboration, of anti-non-collaboration, and of pushing the envelope that you can reflect on to give us inspiration for the future, give WHO inspiration, and all those who wish to do inclusive innovation?
Thank you very much. First, can I ask that you put the timer on?
I got one here.
I was 3.5 minutes.
Yeah, you were 3.5 minutes. That's perfect. So first, 20 years. Already 20 years? 20 years since Bernard Pécoul. Bernard is here. I can see him clearly. Got the support from MSF when they got their Nobel Prize to fund DNDi. Already 20 years. Congratulations, Bernard. Congratulations for having led this organization from the first days to September this year. We all owe you a lot. So what have we done in 20 years? Well, first, we have, since 2003, we have developed 12 treatments for 6 diseases. Not bad, eh? For a relatively small non-government organization. And how have we done this? And this is where I think DNDi is quite unique. We have done this by focusing in our mission on the first term we used was neglected diseases. But after many years, we have realized that it's not the diseases which are neglected. Actually, it was the population who were neglected. And so we have changed the dialectic from working on neglected diseases to working on diseases of neglected population. And I think this is very important because neglected population are everywhere. Neglected population are in Switzerland, in France, in the US, and they suffer from diseases that we think are extinct in our countries. Then the other characteristics is that we have always put the patients at the center. So it is not, we haven't worked to do publication, to be successful in business. We have worked in order to serve patients, and we have always took at very important one of principal responsibility to ask patients what actually they want. And we do have actually at the board of DNDi, we have a patient representative. Now, let me just give you one example. What are these diseases that we have tried to solve? So the most charismatic discussion that we have these days is the development of treatment against sleeping sickness, where we have been able to move the cursor from toxic injection to short oral courses. And we are even moving now to develop a one-shot oral dose. So what does it mean? It means that with these new drugs, it is possible to control and eliminate sleeping sickness. And it is also possible to have a treatment for sleeping sickness integrated into the basic treatment, which are taken part, which are financed by the state as part of universal health coverage. So we are very proud for this. But what's next now? So I told you 12 treatments in our first 20 years. So we want to do more. We have set for ourselves a goal to have developed 25 treatments by 28. So this is only in 5 years. So you have to count us as accountable for what we have put on the table. We also want to change a little bit the way we do business. Indeed, we are a global organization, but we have been very Geneva-centric. And of course, our offices in low and middle-income countries have been taken responsibility for implementation, but the leadership has mainly been Geneva. And we want now to change this, and we want to have more leadership and to help leadership from low and middle-income countries. We want also to see what we can do in order to facilitate the sovereignty of low and middle-income countries, looking even, when possible, at local production. So we will continue to deliver the drugs that are needed by the neglected population wherever they are. But we also want to change the business, the way we do this business. And this is also something that I would like all of you to count us as accountable to see whether we manage actually to do this. Thank you very much.
Thank you very much, Dr. Kuhn. Dr. Gadea, perhaps you have some recommendations for DNDi coming from Brazil. In your own person, you are Secretary of Science, Technology and Innovation for the government of Brazil. Your seminal work on the health economic industrial complex is the basis of Brazil's national development policy. Brazil is a country that from the global south has led the policy discussions. It's going to be G20 president. It has partnered long since with others in tech transfer, capacity strengthening, scientific exchange. So from where you sit as a powerhouse in the global south, how do we push inclusive innovation towards UHC?
First of all, I I'd like to say it's working.
It's working.
Yes, and I'd like to say that for me it's really a pleasure. I follow all the DNDi. I will not follow exactly my scheme, okay? Because
fine.
I follow the DNDi strategy and building. Bernard, we have a very strong relationship since the beginning. We were in Oswaldo Cruz Foundation, after in the health ministry. Now we return to the health ministry, not to do the same things, but to rebuild the Brazilian policy that was completely destroyed in its strategic capacity related to health, to research, and so on. But at the same time, I have good news. Science returned to the Brazil. The relationship and support of WHO returned to Brazil. The relationship with the NDI, I am very stimulated to return to prepare new projects, new opportunities, new agenda. And at the same time, I have to tell you that we have a commitment with neglect disease. I'm not of that kind. I have a problem. I am an economist. Okay,
Nobody's perfect.
but an economist with heart. With heart. But at the same time, I'm joking, and I'm here very, 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 how can I, comfortable. I have to tell you that I've been participating in the new Brazilian development policy. And nowadays, Brazil selected the health economic industrial complex is the production and innovation in the health field as a whole. As Professor told us, it includes vaccine, diagnosis, but it's a system. If you don't know how to use the medicine, how to achieve the access, the patient, it will fail. We will fail. Then, how can I say? It's a productive system. How can I say? It's the system of the 21st century. If we have a new pattern of development that could be sustainable, social, inclusive, and economic dynamic from the economic side. There is not an opposition between economic growth. Brazil needs economic growth and sustainability and welfare. It is a part that's why I'm used to say that in the past, automotive industry, oil, and how can I say aço? Don't know, and or minerals.
Minerals.
Mineral was the driver of development. Nowadays, I think the health has a really, we have a really a responsibility to fight for health as a driver of a new pattern of development. That is by its characteristic that includes at the same time the social field, the economical field, and the environmental field. In Brazil, what you see nowadays, and what we are trying to do that, and we think to prepare a new pattern of cooperation with DNDi. What we have seen in the pandemic context, but not only in the pandemic context, we must be honest. The problem with the neglected drugs, neglected population, it's not new. It's not new. The pandemic only reveal it for people that doesn't know about that. And what still many countries talk to us about open science, R&D cooperation, even local production, but in reality, what we assist a strong asymmetry, a very difficult process of technological, a real technological partnership, some kind of exclusion. I'm used to say, I have the opportunity, I brought here the congratulations of our Minister Nisa Trindade de Lima, the first woman that was a Brazilian health ministry since the health ministry was created. And she's completely committed with this agenda of science. Science, technology, and innovation is a health problem. It's another problem. is a health problem. Then what you see is a very asymmetric world. And we are used to say that the mother of all the inequality is the knowledge, is the knowledge. If you think about gender, race, countries, and so on, then we must face in the health field the problem of world knowledge asymmetry. And I have some perspective. I'm used to say that we must be optimists, to work hard and to build a better world. Brazil just launched a program that is one of the first industrial and scientific and technological policy coordinated by a minister of the social area. It involves 11 ministers, even the ministers, the Ministry of Economic Area, Science and Technology Area, and the governmental articulation area, education, direct to achieve the universal access. It's a completely a new paradigm, how to build, how to think about science, technology, innovation, and industrial policy. If not direct the investment and the effort in science, technology, innovation, and production, in the end of the process, what you see will be inequality. We must act in the beginning of the process. In the beginning of what are the questions we must answer. Then we are present nowadays a perspective that put together the health policy, R&D policy, the industrial policy, but at the same time with the commitment, with the participation of civil society. Other people and other interests will not say what people need. The civil society is absolutely important to participate in the decision process, not in the assistance process, not to give products that we think they need. We think they need. They must participate in that way. And nowadays, in this perspective of the new development policy, and the civil society participate of the process endogenously. Then I bring it not only to talk, oh, it's fantastic, it's good. No, it's very difficult to build, very difficult. But at the same time, nowadays, and our minister is very strong in this point, nowadays, the global and the regional perspective entered in our research, development, and production policy in the health field. Then I think that we will have another 20 years, I hope so, to change the world. We just want to change the world, nothing more.
We do all want to change the world. Thank you very much. I don't know if it will be all of us sitting in this room. I hope there will be fresh blood, nothing against our audience, but maybe not all of us right here. So Jeremy, just to reflect on the role that you will play as the steward of knowledge, and he's advocating for involvement of civil society from the beginning in helping shape the agenda that results with that. How do you envision shaping your role as chief scientist?
Well, I think we could look to the new Minister of Health in Brazil, who was previously, and I worked with her very closely in my previous role when she was the head of Fiocruz. But my understanding is I know she comes from a social science, political science background, head of Fiocruz, a major, including biomedical. That integration of different disciplines is absolutely crucial and is clearly the future. It isn't, there are biomedical solutions. We've heard of some, Bernard's led some, Mary-Paul, we've all led some. But unless you understand how communities and societies work, they won't reach where you want them to reach, which goes to the heart of what Mary-Paul was saying earlier. But can I also just pick up on Brazil? Because the other role that I hope to play in my new role is to encourage everybody to think, how can we all, as communities and countries, invest in long-term scientific infrastructure? Because Brazil has not just invented its current system. Now, it's had the odd blip along the road, politically maybe, but you've been investing in science for many, many, many years, consistently and over time, in institutions, in people, in teams, and in the integration of science into your culture and part of society. We all need that. We all need that, because without a scientific base and the people to lead innovation, then we won't have economic growth and we won't also have health. So I do think Brazil can be a model for how you can invest long-term in discovery science, which will ultimately take you through to innovation.
Very cool. In your experience, the Brazilian model is one, as Sir Jeremy has just elaborated. Are there elements from other countries with which DNDi has worked, or you have worked with INSERM, that you think could provide a perspective?
No, absolutely. Just mention something about Brazil, which has been on the forefront of a political discussion since COVID. You know, the idea was that countries want to regain their sovereignty in the production of health commodities that they consider being essential for their protection and essential for the health of the nation and the citizen. And at the same time, we can see that in most countries, actually, most of the research and development and production of vaccine have left completely the public sector. And it's only in Brazil, actually, as a big country, that there are still two manufacturers. The two manufacturers in Brazil are public sector. One is from the federal state, and we have one of Sao Paulo. But it is important to see that in spite of all the calls that the industry does a much better work and blah, 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 and that the public sector should exit from production of health commodities, Brazil has continued to stick on the idea that the public sector can do it and has been very successful. So now with all the calls and WHO and the Medicines Patent Pool together have a project of helping countries who want to do so to regain the capacity to produce the vaccine that they think are important. We have to follow the lead of Brazil in this area. Apart from that, of course, there are many countries who have been leading on many aspects of innovation and health. Let me call also upon Thailand, who has been innovator in health policies, looking at what the people wanted, to have the people come and choose what should be part of a UHC package, which is quite unique. You have also a lot of investment of other countries, Vietnam, for example, who has been also continuing to do research and development, to develop drugs and vaccine, South Africa. So many countries are still have been and are still now wanting to increase the investment of in science and for health. And I think this is very good sign.
One quick thought from all of you before we put you in your cars and have you whisked off to your next. So the public sector as a key actor in driving R&D innovation, the public sector as a key actor in driving policy innovation. What does everybody else do? Quick thoughts.
I'm looking to I'd like to say that there is not a false opposition between the public and the private sector if the public sector and the public perspective dominate the agenda. I can't ask for a private company, they must have return and so on. There is legitimacy in it. But the public area and the, how can I say, international agenda must be direct for the people needs. If you do that, for example, we have relationship with GSK, Merck, Sanofi, and so on, but the agenda, the priorities, the prices are discussed to achieve the social needs. As economists, I'm saying that we have to put the economy under the direction of the life.
Anything to add to that, or does that sum it up?
All I'd add is none of us should underestimate in the private sector how much the private sector, which we do admire, depends on a vibrant public sector of education, of investment in science, in people and teams. And that may not be balanced right at the moment. But you can't have a vibrant private sector without a very, very strong public sector education science base. And if you don't invest in both, you'll have neither.
Absolutely. Thank you very much. On those words of wisdom, I'm informed your cars are waiting. You're good to go. Thank you for having been with us.
Electric. Thank you.
Thank you very much.
Thanks a lot.
Thanks very much.
We must give our microphone.
Yeah, I want to go mic.
Brilliant. Thank you.
They need it, I think.
Yeah.
And as they leave, we will be turning to the screens and there will be voices from the DNDi teams that you can listen to in their own words. Thanks again. Thanks again.
Take your time. Take your time.
My name is Bona Nyaoke, and I'm the head of the mycetoma clinical program at DNDi. We are working on the development of new treatments for mycetoma, one of the world's most neglected tropical diseases. DNDi, in its past 20 years, has worked on an alternative model of drug development, which we have shown can work. There are a few elements that we can learn from this alternative model that can help us reach universal health coverage. One of these is equitable partnerships and involvement of communities and policy stakeholders in our research setting agenda. When research is led by the countries who are most affected and who are able to articulate their specific needs, then we're able to ensure that health interventions are rapidly scaled up and also integrated into the health systems. The second of which is DNDi has been able to embed equity, affordability, and access in its research and development process. We have seen that with the ability to be able to shape public policies, then we're able to ensure that innovation is not just a privilege of the rich.
Je suis médecin basé en République démocratique du Congo. Je travaille pour DNDi dans le domaine des essais cliniques pour la recherche de nouveaux médicaments contre la maladie du sommeil et la cécité des rivières. Nos malades sont parmi les oubliés des résultats de la recherche de développement. Ils n'ont pas accès aux vaccins, ils n'ont pas accès à des médicaments efficaces, ils n'ont pas accès à des diagnostics. Il n'y a donc un besoin auquel nous devons apporter des solutions. L'innovation médicale doit renforcer le système de santé. On peut avoir un médicament qui marche très bien. Mais c'est pour cela qu'il faut que les patients soient hospitalisés pendant des semaines. Ou alors, il faut que le médecin ou l'infirmier fasse une ponction lombaire. Ou alors, il faut passer par des procédures complexes. Ça devient difficile à intégrer dans le système de santé. Votre approche dans la maladie du sommeil a toujours été une innovation. Mais une innovation adaptée au terrain. Et une innovation faite sur les besoins réels du patient. C'est là, d'après moi, le véritable test de la couverture sanitaire universelle. Savoir si elle répond aux besoins des patients vulnérables et des jeunes. Merci.
I know DNDi since the beginning. In 1999, when the MSF won the Peace Nobel Prize, they set up the DND working group that discussed during 2 years, 3 years in New York, in Paris, in Geneva, what to do to avoid the neglected disease. And then in 2003, we came with the inception of DNDi, Drugs for Neglected Disease Initiative. So 20 years have passed, and DNDi has been a player that has changed the panorama. Dealing with neglected diseases, demystifying the pharmaceutical industry when they say they have to spend billions of dollars, and showing that it has commitments, it has real achievements, highlighting the importance, and being not only a PDP or a partnership, it's a model now. It worked with AMR, antimicrobial resistance, and set up jointly with WHO the GARD-P, another partnership. During the COVID pandemic, it was a real player also. And now, surely, when we are discussing the future pandemic accord, DNDi will be a real player and a game changer in that. So long live DNDi, 20 years of achievements, 20 years of commitment, and 20 years of showing the world how we can deal with neglected population.
The WHO recently announced the end of the emergency response for the COVID-19 pandemic, and everyone is preparing for the next pandemic and looking for pathogen next. However, many have forgotten the burden of disease caused by climate-sensitive infections, which are becoming increasingly important because of climate change. Dengue, chikungunya, and Zika affect millions of individuals in disease-endemic countries in the tropics and subtropics. During outbreak seasons, the healthcare systems are very much overwhelmed. However, because of these infections do not affect high-income countries, there have been very limited funding for these infections, and there is no treatment available. So we have to come together and act now to end the burden of disease due to these climate-sensitive infections.
Many of the questions issues, and perspectives raised in those viewpoints from DNDi colleagues are the subject of our next session, to which I would like to invite Dr. Ibrahima Sosefal, Director of, I believe, the newly named Global NTD program at WHO, and he'll tell us a little bit about that. Welcome. Dr. Maria Guevara, who is International Medical Secretary of Médecins Sans Frontières, one of DNDi's founding partners. Dr. Bernard Ogutu, Chief Scientist at KEMRI, and for those of you who aren't aware of the history of DNDi was born in Kenya at his institution with his support. And Dr. Ben Perry, a mainstay of DNDi's drug development, who has now moved on into the private sector and is principal at Medici. Welcome, Ben. So I'm going to start with you after you've had some water. Dr. Sosefal. Two things. One, the renaming. We want to know a little bit about why it's no longer the Department of Neglected Diseases. It's an important thing. And the second thing we want to know is if the true test of universal health coverage is neglected tropical diseases, as Dr. Pizarro said at the top of the hour, how are we going to make sure that the needs of the most neglected, including those with NTDs, and the increasing numbers of vulnerable are attended to, and commitments to their needs are sustained in the coming 20 years in a changing world with ever more complex, ever more dynamic crises?
Thank you very much. It's a great pleasure for me to be with you today. And I've worked with DNDi very closely when I was working rollback malaria. So it's a great pleasure to be here today. And as you rightly said, first day I moved from health emergency to NTDs. I told the team, why are you calling this a department? It's a global program because we need a global movement where you have all partners, countries, communities, everybody who needs to do something to really address NTDs. While the department is just a small box in WHO organigram, nobody cares about department in WHO. We need a global movement, a global program addressing not only the health intervention, but making sure that we work across sectors to address and tackle the real determinant of these entities. Many people talked about already, the socio-economical determinant, the environment, climate change, and everything we need to address to really prevent and eliminate entities. And so when you talk about universal health coverage, it's very important to move from the concept and framework to real delivery. And when you talk about NTDs, many people already said it's not just about neglected diseases, but neglected population. And when I was deployed to DRC in 2019, tackling Ebola, I told the team, in the early 90s in Senegal, I was already crossing rivers to go to address, investigate outbreak, respond to emergencies. Now in 2019, I'm crossing a river, taking a helicopter, a car, to be able to access to the population we need to protect. So this is a big problem, meaning that we have been talking about universal health coverage for many, many years, but putting the right content and the right service delivery on a timely manner with the quality we need is not still there. And I used to ask my colleagues working in health system to come with me to the field to know where to start when you talk about universal health coverage. Because I went to a city in Congo called Beni. We identified more than 300 health facilities, informal health facilities, not recorded anywhere, with no professional workers. And they call it tradi-modern. So, of course, Ebola transmission was happening in those health facilities because of, the lack of IPC and everything, So now, if we continue neglecting some population, we will never be able to have universal health coverage. So no universal health coverage without entities intervention for me is important. And we need to move away from the idea that you can deal with one health problem today and tomorrow you deal with another health problem. We have seen during the pandemic that people who are not, taken care of because of for non-communicable disease, they suffered really on died mainly from COVID. So it's the right time when we plan for universal health coverage, for climate change mitigation, for pandemic preparedness. We think about a holistic approach, because if you compare entities intervention for elimination, eradication, and outbreak control, pandemic control, you have exactly the same intervention. The only difference is the time frame. You use the same health workers, the same community. So why should we plan today for pandemic preparedness and response? Put money for pandemic and wait for tomorrow to address NTD. I always tell my colleagues in health emergency, we went to Uganda for Ebola. We spent millions of US dollars, and we were very happy to stop the Ebola outbreak, but we leave the field, leaving people with the NTDs. So is it really a right public health decision? We need to think about the way really we are planning and working together. We need to think about the people-centered approach. So you will not tell the people, I'm here today for NTD, tomorrow I will come for pandemic, or vice versa. And that's why for me, looking at the current funding environment, where you have funding for for communicable disease, I mean, you have funding for HIV, TB, and malaria with the global fund. You have Gavi for vaccine preventable disease. Now you have the pandemic funds. Again, the only communicable disease neglected are the NTDs. Are you going to spend so much money just for those diseases? And we will think about next time what to do for NTDs. I think this is time now for us to really be more serious about universal health coverage, making sure that we think about the people who are affected, and we use a general approach to address the critical health problems. Thank you.
Thank you. Dr. Guevara, perhaps nothing is going to concentrate minds like the many crises we have seen that are waterborne, driven by the climate crises, and the introduction of neglected tropical diseases to new geographies. We have endemic dengue in Europe now. If we are to respond to the call that Dr. Sosefal has made, what role do you think that innovation can play in facilitating climate resilient communities within adaptive efforts?
Thank you, Spring. So I'm assuming you can hear me for the introduction and to DNDi for this invitation to be part of this amazing panel. I will try to stick to my speech because those who know me, I can speak forever on climate change. So my title that I've actually titled my speech is actually Everything, Everywhere, All at Once. But
Where does
sadly,
that come from?
but sadly, it's not for everyone. So bear with me. There is some logic to this madness, and yes, I am making a reference to the movie of critical acclaim, and we're in a 360 movie theater, so it's quite apropos. But it was built on an imaginative concept of multiverse, but also of possibilities and rebalancing. And so while parallel worlds seem to be fiction today, many scientists actually are seeing this as a possibility, actually. But until the research studies actually confirm it, and we figure out how exactly to verse jump or beam ourselves out, we remain grounded here in our one verse. Unfortunately, the planet we are living in this universe, is hitting its limits, right? From abuse, overuse, misuse, unequal use of by us humans, and is fast becoming unlivable for the already most vulnerable. So while scientists have yet to prove multiverse exists, the science on climate change, however, is clear. Climate change is real, and it is both a health and humanitarian crisis. So the Intergovernmental Panel on Climate Change in their sixth report offers us a very, very grim verdict. The planet is no doubt heating at a rate we've never seen before, and we are at fault. And there is little hope now remaining of avoiding a worst case scenario. And the effects of climate change will be overwhelmingly negative, and it's impacting the most vulnerable today. And the report unequivocally also links climate change to negative health impacts. And because climate change is a health crisis, and it affects everything that is health, from extreme heat causing increased disease and death, as well as the more regular and more severe extreme weather events, to rising food insecurity leading to much more malnutrition, to rising negative impacts on mental health, worsening burden of chronic diseases, and of course, to increasing incidence of foodborne, waterborne, and vector-borne diseases, as well as emerging infectious diseases, as we all have experienced in COVID. And for MSF, a large proportion of the health problems we manage in our projects are these climate-sensitive diseases, as diarrheal illnesses like cholera, or vector-borne diseases like malaria, dengue, or yellow fever, infections associated with undernutrition, of course, emerging infectious diseases as Ebola and COVID, as mentioned already by Dr. Sosefal. So climate change is also everywhere. From the Lancet Countdown report in 2020, no continent, country, or community is immune from the health impacts of climate change. It doesn't matter where you live. Climate change threatens health, and basic necessities will be disrupted. And these past 3 years have shown us all that no one is immune. And the pandemic has proven that viruses have no borders, as climate change has none. Climate change, however, does not affect everyone equally, and neither did COVID. While COVID may have touched us all, the ongoing impact, however, remains still uneven today. And similarly with climate change, the vulnerability burden is still borne disproportionately by those in humanitarian hotspots, and they are where MSF has worked for the last 50 plus years. Climate change is a humanitarian crisis, and in humanitarian settings, compounding, converging, and cascading emergencies do not allow for an already weakened system to recuperate, adapt, and bounce back so easily. So in MSF, here especially in MSF Switzerland, we're looking at climate change through a planetary health frame. It is the newest of the disciplines, and it acts like an umbrella of all those other disciplines of environmental health, One Health, and climate change and health, because it looks at how global pollution, climate change, biodiversity loss, altered biogeochemical cycles, changes in land use and resource scarcity as food and water are having an impact today. What is especially important about planetary health framing is the centrality of the humans and our relationship with the planet, and it calls for connectivity and the building of multi-sectoral alliances. It looks at how humans are altering the natural world, how our expanding population, changes in technology and patterns of consumption and production are fundamentally changing our land, atmosphere, and oceans, and making our planet sick, and therefore us sick. So essentially, it's a stark reminder that our human systems are broken and how it is causing a break in everything, everyone, everywhere. And through this lens, at MSF, we are adapting our programs to be more efficient and climate smart in parallel with working to mitigate our footprint. Operational adaptation is also about context analysis and assessments and innovating how to better anticipate, how to predict, prepare for, and respond to emergencies. An example, malaria is one of the biggest diseases that we address in our projects today, nearly 2.7 million cases in 2021 alone. In the last year, we started a pilot project in Lankian, South Sudan, where we have taken our meteorological and climate anticipation project, linked it with the malaria anticipation project, seeking to use the climate information and environmental factors and bridging that to epidemiological data and looking for the impact on seasonal malaria, hoping to anticipate better and have a timely response. During our COVID response, we had to be innovative in how we reach patients who could not come to the health facilities due to lockdowns, stigma, or fear of diseases, similarly as we saw in Ebola. We ramped up the use of telemedicine. We ran online IPC trainings and health promotion through social media. We even ran WhatsApp groups for traditional healers. And in Eswatini, we set up the use of video observed therapy to reach the MDR TV projects or patients by providing them smartphones so they could call in and film themselves taking the medicine. And so this now has become part of the national health programs. So just really to say that being climate smart requires agile and inclusive innovation, thinking outside the box and designing projects with patients and communities as partners. And it takes inclusive, radical collaboration at the very local level to make real impact globally, everywhere, for everyone. Thank you.
Thanks. Dr. Ogutu. 20 years ago, Kenya broke with convention and decided to participate in the founding of an institution that was responding to a crisis of the time. And as Dr. Guevara has just pointed out, we are faced with a new era of crisis. So how are you thinking about disruption now, again, for the most neglected, the most vulnerable? You're faced with them every day.
Thank you very much. And it's a pleasure to be here, and thank DNDi for, I call DNDi one of the, it's more of an African child, very disruptive. At the age of 16, it gave birth to the first child called God P. At 19, it gave birth to another child called Antikov, and now it has Panther. So I think it just shows how disruptive it is supposed to be. And I think possibly one thing that I would say, having been part of the DNDi fraternity at the beginning, and possibly looking at the disruptive way of possibly showing that product development can be done anywhere, anytime, and still achieve the global standards. I think that has happened well in the 20 years, and I would say DNDi has provided the fish to those of us in the South. But I see the next 20 years is for them to provide us with the knowledge to fish. And this is where we want to see possibly in the new disruptive system, or possibly in the global village where we are in, which makes thinking difficult, in that most of the time we say what you think becomes your actions, and your actions become your character. And if we stop thinking of neglected or possibly or the populations, then I think we'll have the right way. So we just need to reboot our minds and see ourselves as part of that global village, that if one of us is not safe, none of us is safe. And for this, I think we need, just like the African oral myth is that to go far, we have to work together. I think this is the time possibly I would ask my brothers in the North to have the hard discussions with us in the South. We need to put our money where it hurts most. And I think it is time that providing solutions might not be the ultimate game changer, but being part of the solution, I think, to the South. I would want to see phase 1 studies done in the region where the diseases are in. It might take you 2 years to plan for that study, but once it is done, the information and the knowledge and the capacity is built. And that's the only way we'll get R&D in the South. And that's the only way we'll demonstrate to our government that these things can be done and they have to invest in those. And I think, to me, I see that as the next disruption that possibly a player like DNDi can bring on board. And that's what I see as those of us who have been with DNDi over the last 20 years. We want to see that shift in the thinking. And I think it is going to be a hard discussion, but I think this is where we need to meet so that we can get this discussion, because there's the clamor for manufacturing in the sub-Saharan Africa. And it's a simple question that I have asked even my own government and said, you want to manufacture whose antigens or whose molecules? You have to generate them if you are going to manufacture them. And I think technology has been on our side, because drug discovery with artificial intelligence is much easier to invest in and will cost much less in the South. Because I've been able to sit with some of my master's students in the university doing basically database mining and chemical database mining. And we have been able to develop targets and identify those targets that we can move to the next level. I think this is what we want people to invest in. And this is what we need to get moving so that we can get to the point where we can start moving to the same level where the rest of the Northeast, because I think if we don't get there, then I think the global South will continue being the problem. And we don't want to be the problem. We want to be part of the solution. And I think this is a disruptive way of looking at things, but I think that's what we need to. And I think these some of the things that we think possibly, if Jeremy was around, I would see WHO push this button harder. Let the heads of state say, nay, but tell them this is where we need to go. And I think, to me, that's the disruptive nature that possibly I would want to see, is that let's sit together and come up with the solutions. Please, we would like to be helped, but I think we need to be made to do what we need to do, because I think the capacity is there, the knowledge is there, the infrastructure is now being available. When we did the first phase 1 study in South Africa for the first antimalarial discovered in South Africa, initially the main thing was to do the phase 1 in Australia. We said, let the South Africa government put the act in place. It took 18 months, but they got the phase 1 study done. And that has made sure that South Africa developed that capacity. And now they move the next level. So I think, to me, that is where I see DNDi in the next 20 years to be disruptive and possibly help us get the R&D capacity in the South moving. And I think all of you, let's disrupt and reboot our minds to think as one globe, and possibly is a village that we are in, because the change of knowledge and possibly the transmission of information. When there's the issue around COVID, all the anti-vaccine messages in the North were in the South, and they just messed up everybody else. So I think the flow of information, we are in one village. Let us focus on a common solution, and possibly let us be on the same page. Thank you.
Dr. Perry, Ben, you brought this disruption of AI to DNDi, and Bernard is talking about that being where the game is in the future for the Global South. Do you agree?
I agree absolutely that one of the big parts of AI and AI's future in drug discovery is the democratization of the process, right? I think that that's absolutely true. And there are, really great examples from when we were working, last year with DeepMind, when they came with what is the biggest breakthrough in artificial intelligence in drug discovery, or in the life sciences, with the AlphaFold protein database. And we spoke to them way before this was actually announced, before there was huge press. And they were clearly at the time thinking about monetizing it. I think, they were, what do we do with this? And we had some discussions. We said, no one's going to listen to you. No one's going to believe that you've come up with this fantastic breakthrough if you try to turn this into a commercial endeavor. Put it out in the open. And they were clearly thinking about that already. It's not DNDi and the team at DNDi that pushed them to do that, but they did do it. And because they've done that, and they drove that from democratization, it has had an enormous uptake. So it does, as you say, it enables people to work in a way, but the actual fundamental infrastructure is not that essential. And I think that, as you say, it's almost on a level playing field. Where I would come with a caveat on this is that it's still artificial intelligence, and it is not the panacea that everyone thinks it might be, or certainly everyone sells it as, let's put it that way, yet. So the important thing is to get up to speed and make sure that it is global, and then everyone moves forward together. And we had this idea in DNDi when we were starting to speak with AI companies, and we realized that there's actually a niche in particularly global health and in DNDi-like organizations that can really help on this. And it's this idea that Dr. Farrar mentioned earlier about togetherness. Working in partnership, working particularly with people in the private sector, it has to be a win-win, right? It has to be a win-win from both sides. And the way that one can make it a win-win, particularly from anyone working in this in the commercial space, is you can help to prove their technologies and help to enable the technologies in a way that brings them a win on the technology, but also brings a win in the diseases that DNDi and others work in. Again, AlphaFold's an example of that. It's really important, I think, that DNDi and those working in the space make people aware that if you're working again, in AI spaces, that we're here, we being DNDi, we're here and we're prepared to work with people and we're prepared to show how this technology works. And because we work in the areas that we work in, we can be very open about those successes. That doesn't happen in the pharma industry. I mean, I come from the private sector and I work in the private sector. It's shut down. We don't talk about it. Any successes, we would not necessarily shout about a fantastic new technology because it's maybe there's a competitive advantage. So if you're someone who's developing that technology, it's a really, really great way to work with organizations like in the global health space to show that your technology works and to get the attraction of then the commercial sector saying, well, we trust DNDi because the pharmaceutical industry does trust DNDi and MMV and other organizations. They have that profile. If it's working there, then we really need to get in on this. And I think that as you're saying, the democratization through AI is a really key part of that. I also think it's very important to think and to realize that if we're talking about, one of the things that we were hoping to touch on here, this whole idea of new modalities, we work mostly in small molecules in global health. You see all these new breakthroughs coming through, and I can attest to this. We're on the cusp of an enormous breakthrough in terms of new ways of treating diseases in the private sector, mostly in oncology, cardiovascular areas. Huge breakthroughs are coming. Everyone is incredibly excited. Most of those things are going to fail, but it is very, very, very exciting. The next decade or so is going to be huge. How we make sure that that can then also impact globally rather than just in the areas that the commercial sector are interested in is a very difficult challenge because the diseases, particularly infectious diseases, the fundamental science is not necessarily as deep as it is, particularly in oncology, just because of the way that science has been invested in. And at the same time, it's arguably more challenging. It's very, very difficult to think about how to treat infectious disease compared to other diseases when you're thinking about an infectious agent inside a host. So it's very complicated. So I think it's very important that, particularly in the global south, if there are researchers focusing on that and becoming the experts there, because you say tying into climate change, as it becomes a problem, as it starts to move elsewhere, it's important that those experts are there in the original endemic regions, and then it'll help with the exposure. I think that's really important. I think that DNDi need to push on that. DNDi has always been quite pugnacious and pushy, and I think that's one of its great strengths. And part of the reason I joined DNDi was because just seeing this opportunity to come in and work on a collaboration that had brought all of these pharma companies together that normally wouldn't be seen in the same room, and all of a sudden they're all going to be working together. That's why I joined DNDi. That's why I left the private sector to come and work with Charlie Mowbray and others on that project, because I thought, and if an organization can do that, if they can get these people in a room together, and this is 6 years ago, I mean, that's incredible, and it should not be forgotten how fantastic that is.
Thank you. Dr. Sosifal, I'm going to give you the last word. And I'm going to give it to you because all of this falls in your purview. Everything from how do we make sure that to get to our patients, we don't need boats and helicopters and wrenches and all of that, to reforming our own institutions so that they are not contributing to a worsening climate crisis, to adopting and adapting all of the magic and mystery of artificial intelligence and whatever else is coming down the pike. You're responsible for that in the area of neglected tropical diseases and populations. You might want to rename your program, but rename. How are you going to consolidate this?
Thank you. It's all about partnership, understanding that no one institution can really do great things. And, one of the big gaps I already see in the WHO program is the R&D, because how we are going to, work with DNDi and other partners investing in R&D, artificial intelligence, if you don't have the platform to be able to coordinate and agree together on the tools we need for the future, both to address, the consequences of climate change, but also to be in a more preventive, side to really address those issues of deforestation, because if you look at all these zoonotic diseases, with the level of deforestation we are seeing in many tropical countries and the loss of biodiversity, if you don't make sure that we address all those in a partner, in a well-coordinated manner, it will not happen. That's why for me, the idea of global program is important, because we need to be able to bring all, the brands and, capacity together, but working very closely with national institutions where we need to, continue, raising the capacity, but also very closely with communities, because everything we do on the research should be linked clearly to implementation for impact in terms of prevention and control of diseases. And I'm very happy in the past I was able to do it with Cambridge on the malaria side, because we felt at certain point that the data we were working at global level for malaria in Africa was not right. So we spent 8 years doing research in Africa, real population-based data with Noor and Bob Snow to publish this changing risk of malaria in Africa, and taking it from where for evidence-based planning for impact. So I think this is something missing in NTDs. It's very easy to keep doing the same intervention almost everywhere, mass dot administration, but it cannot be like that. We need to be evidence-based on using all capacity and new technology we can have for greater impact. Thank you.
Thank you. Well, we're looking very much forward to the future of innovation for entities. I'd like to thank our panelists for their thoughts. And move to our final session, which will involve all of you. So get ready. Thank you very much. To kick off this final session, I would like to invite two sides of the coin. On the one hand, Dr. Ambassador Honze Koto, Deputy Permanent Representative of the Government of Japan to the UN in Geneva. Please, Ambassador. And Ms. Rosemary Mburu, who represents the civil society perspective, Chief Executive of Wachi Health Kenya. Thank you both. We didn't have time to mic them between the sessions, so we're going to ask you to please use handheld microphones if that's okay. And so we're going to continue this journey from the past 20 years of DNDi and the past 20 years of everything that's happened in global health and look to the future. And I'd like to start with you, Ambassador Honze. Yeah. The government of Japan has long been an advocate for human health security through UHC. That is not something that started now. You are currently president of the G7, and in that presidency, you have instituted a global health task force that prioritizes health security, innovation, and global health architecture. As you look to the future, and the role of Japan in that future. How do we invest in inclusive innovation for everyone to achieve UHC?
Yeah, thank you for DND for inviting me for today's as a speaker. First of all, even though I'm wearing a G7 badge, it's too tiny to show the G7 presence. So first part, I'd like to promote, yesterday we have terminated our G7 leaders summit in Hiroshima. So I'd like to show which is the achievement in the summit in the field of health. And Japan, as introduced by Chair, Japan has consistently advocated the importance of international health within G7 since 2000 in Okinawa summit, which also led to the launch of a global fund now today, and including discussion at 2008 and Toyako G8 summit, and 2016 Iseshima Summit. And every time we made finance some kind of commitment in the field. And I know as I have worked in the field of economic cooperation in the Ministry of Foreign Affairs and also for the JICA, in this field, money matters. The situation of COVID-19 itself is improving, but efforts must be made to prepare the next crisis or next pandemic. Based on this recognition, this year's summit focused on first, develop and strengthen global health architecture for public health emergency, and second, contribute to achieving more resilience, equitable and sustainable universal health coverage through strengthening health system. And third, promote health innovation to address various health challenges. Well, these pillars of the discussion. And regarding the first point, global health architecture, we confirmed the importance of governance at the head of state level, strengthening financial sector and the health sector cooperation. Financial initiatives, including surge financing, to provide funds quickly and efficiently in times of crisis and setting international norms. With regard to the second point, more resilient, equitable, and sustainable universal health coverage, we highlight in the financial contribution to global health totaling more than 48 billion US dollars from the public and private sectors with a view to achieving this goal. In addition, G7 will continue to support efforts to achieve universal health coverage such as Triple I, Impact Investment Initiative for Global Health, as an initiative to promote private capital mobilization through impact investment in global health, and G7 Global Plan for UHC. Furthermore, as a third point, G7 noted the importance of promoting health innovation, including response to pandemic and drug resilience, MR, and agreed to launch the MCM delivery partnership for equitable access to medical countermeasures, MCM delivery partnership, to achieve equitable success to MCMs. Based on the principles for both fourth in the G7 Hiroshima vision for equitable access to medical countermeasures. High-level commitment to global health, including not only in the G7 Health Ministries meeting communique, but also in the leaders and foreign ministers meetings communique, shows Japan's determination to address global health challenges. While building the G7 meetings outcomes, we would like to actively contribute to the discussion leading up the UN General Assembly Hall meeting on UHC, PPR, and TB in coming September. And finally, I have to answer to some questions raised by your side. That, of course, in order to realize some kind of innovation itself, we have to engage private sector. So it's quite important to make some kind of balance between the investment incentives of private sector and the public sector's policy. And of course, in order to deliver and some kind of any vaccines or medicines and equipment toward end users, we need some kind of engagement of all the stakeholders in the field, which I heard that many discussions have been made already in this symposium. But we need to, in order to realize universal health coverage, my final point is to engage all the stakeholders, including the informal sector. Thank you very much.
Thank you very much, Ambassador Hanze. Rosemary, you represent the people. You have heard a lot said today about achieving inclusive innovation from government, from WHO, from DNDi, from others. Do you think that what you have heard gives you confidence that there will be a people-centered approach to innovation and that it will contribute to UHC?
Yeah, so thank you very much for the opportunity to share on this panel. And as I come to your question, Spring, I just wanted to thank the ambassador here. The G7, the Japan G7 presidency has anchored UHC, R&D, they had 100 days plus, and global health security. And within that also there is language around people-centered approaches in R&D. So we are grateful for that leadership. When I was thinking about this topic of inclusive innovation, of people-centered approaches, there are two things that came to my mind. It was a memory. I first remembered when ARVs first came to Africa. And actually before the ARVs got to Africa, there was a lot of talk that we Africans and basically communities, because you are thinking about who actually is most affected and where is the medicine going. We were talking about here on this panel, I think the earlier panels, low and middle income countries, where you have the biggest burden of disease. And there was a talk that actually we couldn't do the ARVs because we couldn't tell time, and ARVs needed like to be very strict on time and adherence. And there was the talk that no, you know, we on the continent could not actually tell time, and so we were locked out of ARVs. That's something that came to my mind. The other thing that came to my mind is about over 10 years ago when I started this work in global health, my first entry point. Actually, my first assignment that I got where I worked first, it was an NGO that does HIV coordination among civil society in Kenya. And my first assignment was to work on community preparedness for clinical trials. It was a clinical trials for an HIV vaccine. I still remember that time it was IAVI, CAVI, KEMRI, you know, like really working in that space. And so when I was thinking about fast forward to 10 years and the challenge we had with COVID vaccine, for example, in terms of uptake, in terms of absorption. And I was thinking about the people that were coming to us saying that, you know, you told us 10 years ago that you are working on an HIV vaccine. We still don't have an HIV vaccine. And now you are telling us to go take up a COVID vaccine that, you know, like within 1 year, we have this vaccine. And it shows you, like when I was thinking about that, it took me back to community involvement, community engagement, public education, public perceptions and understanding of science. Because like for the HIV vaccine, it has taken a lot of investment and concerted efforts around educating people, you know, how, you know, the process of development, how you prepare yourself, what's the process, basic science around that and all. But I think the nature of this, the COVID-19 vaccine, how rapidly it was done, the oversight around community engagement, the oversight around public education in terms of even saying like, yeah, it's been very short because it has leveraged many, many years of science, you know, in other areas. So that gap, I remembered about that gap. And then very recently, I was involved in a conversation because I thought, okay, now with science and R&D, I think we are doing a better job of community involvement, community engagement, thinking about the people. But I had an engagement a couple of months ago, this year still, in terms of setting up a community advisory board for some clinical trials for a product. And the clinical trials are in 4 African countries. And as we were working with a research sponsor around setting up this community advisory board, one of the things we asked for and we said is that we would like to see the protocol, you know, for this. And they said, well, if the community advisory board wants to see the protocol, maybe those are not the communities we are talking about. So it is the assumption that we cannot understand science, we cannot understand protocol, we cannot be part of some stages of the development, especially like design and all that. So what I love about what DNDi is doing is that talking about inclusive innovation from design all the way up to when you have a product, when it comes now to implementation, to uptake, and so on and so forth, the whole continuum. And that's very important because it affects so many aspects of how then that product ends up impacting. So I think when we talk about universal health coverage, when we talk about innovation, we are talking about saving lives. That is really what is at the core. When you remove the jargon, when you remove all the technical language, at the end of the day, is about saving lives, is about people. And so people-centered approaches for UHC, that's how they look like. Inclusion, a process that is co-created with communities, with end users, not just for certain stages that can help us tick the boxes. It puts communities at the center, basically, and that process also leverages communities' expertise, experiences, perspectives, etc. Community feedback, you know, around the development process, you know, and so many aspects of the product. When you get communities' input, not just at the beginning, but as you progress, it's really important. I like what Dr. Ibrahim really is a community advocate. I see him like he's a comrade actually, and very excited to see that we have an advocate who's really passionate about inclusive innovation, putting communities at the center, people-centered approaches. Because I think people-centered UHC approaches is also about understanding the nexus between health and all the other things that we are seeing, the climate crisis, war and conflict, even food prices and food security, and so on and so forth. In many settings in Africa, we prevent malaria, but then the cyclone comes and actually gets to be the thing that kills you. And so that's really important. And so linking that with UHC and the kind of things we are calling for and the things that we want to see. Number one is we are calling for, as we, in the lead up to the UNGA, in the lead up to the high level meeting, we are calling for political leadership. It has been mentioned here on this stage that we really need a strong political leadership for UHC. So we are looking for champions from the country level to actually, because when we talk about UHC, the game changers and the thing that actually happens for us to then say countries are making progress towards UHC happens at the country level. So New York is, you know, political. We go there for the political framework, for the political support, the champion, but really where action and change and the saving of lives happens is at the country level. So within the UHC 2030 movement, there's what we call the political agenda. And the political agenda has about 8 asks. and they are very similar to what you would ask for even inclusive innovation, because it's political champions, for this. It's about ensuring that you're leaving no one behind. In fact, that's a core principle for UHC when it comes to the high level meeting key asks. Pretty much just like, what we are talking about today, leaving no one behind, ensuring that you don't have populations that are neglected. And with UHC, it's not just populations that are neglected. It's also about you have populations that are either criminalized because of certain characteristics. So you have all that. And it's important for us to ask ourselves, who are we leaving behind? And most of the cases, it's the people or the populations that have the neglected tropical diseases or neglected diseases. So basically, it's about bringing everything together. There's also a lot about ensuring that we adopt laws and regulations that help us to access health. And that also can include laws and regulations that provide a conducive environment for innovation. Thinking about how innovation can take us closer to equity as opposed to actually deepening the divide of inequity. There is a whole issue around investing more and investing better. I won't go through the whole 8 asks, but I think this one is very important because it talks about investing more specifically for the high level meeting. The ask is around primary healthcare, investing more around primary healthcare. And as I was reading DNDi's work and philosophy, one of the most exciting things I saw there is that it's really committed to developing safe, effective, and affordable, medicines. But those that can actually also be delivered through the primary healthcare. I like that very much. That primary healthcare system can be set up to actually deliver technology, deliver the tools that we have. And that's, I think, going to be a very strong connection around innovation and primary healthcare. And when it comes to financing, again, invest more, invest better is also talking about domestic resource mobilization. So just thinking about how can we continue to have strong country ownership? How can we continue to have research agenda that is set by the country through the national strategic plan, etc. One of the speakers said, whose research agenda are we actually implementing? And so I think from a community, from a civil society point of view, we are very keen to, partner with our countries to ensure that we can generate more domestic resources, because that, I think when you think about the issue of imbalance and inequity of power and voice, we have to think about domestic resources as a way to ensure that the research agenda in Africa, in our countries, is actually African driven.
Thank you. There's a lot of food for thought for all of us there. I'd like to invite you as the audience now to reflect upon what has just been said, to perhaps raise questions or your own comments about what's being put forward in the course of this entire discussion, but especially in the agenda that's being set going forward for the G7 and through the UN high-level meetings. I am being blinded by the lights. I can't actually see at the moment. There's a hand up anywhere. All right, sorry. Yep, please go ahead. Introduce yourself briefly. And we have about 6 minutes for questions, so please, short and sharp is a way to do it. Thanks.
Hi, everyone. This is Rafal Khalifa, and I'm representing the International Pharmaceutical Students Federation and the International Pharmaceutical Federation Young Pharmacist Group. So I'd like to inquire about one point, like you have highlighted about the country level leadership and how this can encourage the change and how it can drive change. So what are the steps taken to encourage or promote or like lead those countries to achieve the championship, or what is the driver for these countries to achieve that? So this is one question. The second one question
You get
only?
one question.
Okay,
Yeah.
thank you.
Otherwise, no one else gets a chance to ask. We're
Okay,
trying to be
thank you.
democratic. So,
Thank you.
does anyone else have a question? I'll rely on my colleagues on the floor to help with the mics.
Hi, my name is Wes Onukwanga, and I represent the, excuse me, the Civil Society Engagement Mechanism for UHC 2030. For those of you who don't know what UHC 2030 is, it's a multi-stakeholder partnership to advance UHC at the global and region and country levels. And I wanted to just add a little information on what Rosemary has shared about the action agenda, this document here, that we have developed in preparation for the high-level meeting on UHC. And it lays out 8 key asks that range from some of the stuff that Rosemary has shared. But action number 3 focuses on creating enabling environment for R&D, for innovation and technology for health in order to advance UHC. Goes into great details to give specific recommendations of what world leaders should consider in September when they are negotiating the political declaration on UHC. One of those is to adopt policies and laws and regulations that strengthen the ecosystem for health technologies and innovation, but with a focus on increasing access to the marginalized and neglected communities, most of whom happen to live in the global south, and also calls for world leaders to invest more and more sustainably into R&D, and again, focusing on making sure technologies are available to the people that are most affected by health problems. I'll stop there. Thank you.
Thank you very much. We had one question and one comment, and unfortunately, we're almost out of time. So I'll give the floor to you, Rosemary, to answer that last question.
Yeah, so I think at country level, and WISWA has the action agenda actually has policy recommendations that you can take forward. So that's a really good resource. But at a country level, it's very important that the research agenda is prioritized through the national strategic plans. Some countries do not have national strategic plans for research, do not have a country research agenda, and that is a really good starting point for this kind of political will and political support. And then have defined mechanisms and institutions that actually then provide the leadership and help to govern and help to take that forward. I'm thinking when you talk about investment, it's very important that there's how the resources are collected, are governed, are distributed, and all that. In Kenya, for example, the National Research Fund is one, I think it is a really good agency, institution, or idea. It exists, it's growing in strength, but I think the starting point is that you have a mechanism that can actually help to mobilize and coordinate and govern the resources. And I think in future, as we progress, that is going to really help in terms of ensuring that we have resources earmarked and put aside for research at the country. Of course, there are many details and technicalities to work out to actually make it very effective. But I think that's a really good starting point, that it's entrenched within the National Strategic Plan. There are institutions like the National Research Fund. There are policies that talk about, like 30% out of the total national budget should go into research and so on and so forth. So I think that's, one way to actually ensure that there is country ownership, country leadership, and prioritization, but also investing in the research infrastructure in the country. There's so much capacity in Africa. There's so much capacity. There's so much that has been done. I think investing in that, continuing to to support that capacity and the infrastructure, I think is really great in terms of where we go in the future.
Thank you. And Ambassador Hunsay, that is some of what the G7 is considering in strengthening the global health architecture.
Yeah, thank you for your question. But G7 is only 7 members.
They can't do it all.
So we have to realize universal health coverage with all over the world, and we need engagement with G20 as well as UN General Assembly's high-level week for the UHC. But I'd like to say, point out that right now, yes, we are discussing IHR and the new pandemic treaty. And in that schemes, yes, we have been discussing about universal peer review of health. And that peer review will require some kind of a financial commitment of each government and health sector, including not only the developing countries, but also developed countries also receive that kind of peer review. And not only the General Assembly's high-level meeting discussion, but every year, for example, 5 years, each country can make a commitment of financial contribution, and also for the health sector's investment to some extent. And that kind of transparency will be implemented in the coming future. That will be a good case for in order to promote the universal health coverage. And of course, we are ready to provide necessary technical assistance to those countries which need such kind of technical assistance to improve, to prepare for such kind of review.
Thank you. Yeah. Thanks very much, President. Thank you, Ambassador. Thank you very much. Thanks. And so we come to the close. Thank you all for being such an attentive audience. Thank you to those joining us online, to those of you in the MSF hosting. If you are in the MSF hosting, please know that you can come into this room and watch the films that were played earlier. They will be played again for you at the end. It has been a privilege to have been part of DNDi, to have hosted you all here, to have been your MC. I don't know what the M is. Thank you. I will hand back to Dr. Luis Pizarro, who is the, I guess, what? The final word?
Yeah.
The wrap up,
with this.
the capture of all the challenges.
Thank you,
and all of the.
Thank you. Thank you very much to you, and thank you very much, of course, for all the speakers to be with us. I would like to thank also the DNDi team who organized this, who did the movies, the films, who prepared that very hard. So please, I would like we give a big applause to the team on this one. And well, as you heard, we're celebrating the 20th anniversary. And to make that happen, of course, a lot of people. I talked about the institution, the founders at the beginning. So we very much appreciate the work we have been doing with those institutions. But beyond institutions, there are the people, the persons who have created this organization, have lead this organization, and of course, there is somebody I'm very proud to take over after the 20 years he was leading this. So I would like you to join me in a round of applause for Bernard, who is today with us. Thank you very much, Bernard. I think you have inspired several people here around the table, and you represent everybody, all the former staff, chair of the boards, etc. here. And Bernard, when I asked him, well, what are the keys, the keywords, or the tips you are going to give me to take over after you, You said it's very simple. There is just one thing you need to keep in mind always, is the patients. And all we're doing here is for the patients. And I think this is also something that DNDi has in mind, and all the teams that are working around the world that are following today, they know every day their work is for all the patients you have here in the world. And this is what is still motivating DNDi, and this is what is bringing all those partners from the private sector, public sector, from government, from academia. So we count on you to be with us for the next 20 years, because there is so much work to do to really make those patients not anymore neglected populations. So we count on you for that. And thank you very much again for being with us. We have now some drinks outside. Hopefully the meteo, it's very good today. And I invite you to go for a drink and celebrate the 20th anniversary. So thank you very much.